just gonna head over to. Hello.
Hi, Alyssa.
How are you?
I am great. I am great. How are you?
I am great. I don't know if anybody can tell, but I'm in a little bit of a different environment today. I'm actually out of the New York Wappingers office in our new Link room. So some of you might have recognized it from some other product showcases we've done. So I've got a really cool setup here, Shane. So I'm excited. I wish you were here with me, but I know you've got a cool sim lab too. So
yeah, no, I'm really looking forward to it because I think in the soon I think we're going to do some tips and tricks from the Laerdal link. We're going to have some product demonstrations and just really how to utilize this equipment better, obtain those learning outcomes, and really get into building better outcomes for our patients and our community. So welcome to episode 1 of 2022, season 3. So if you're new to the podcast or to the webcast, this is where we get to show you some tips and tricks. It's really designed for end users on how to use our products or how our products can be used to capture those learning objectives that you all have. And this year, we're going to start it off strong. We are looking at mothers and babies deserve to survive and thrive. And boy, oh boy, do we have a jam-packed agenda full of great guest speakers. And we're going to do live stuff. So why don't we look at that agenda, Alyssa?
let's get into it. Yeah, great introduction. We have a lot to cover, but we're very excited to have everyone here with us. Again, if this is your first time watching the HSL webcast, welcome. Shane and I are co-hosts, and we tend to have kind of a usual way of doing our webcast. And the first 2 segments are kind of where we have a little bit of flexibility in terms of guest speakers, different products that we demo, and then we have our typical hot topics, giveaway, and clients corner. But starting off with our very special segment of today, we have 2 guest speakers coming from the Laerdal Global Health to talk a little bit about the mission, the impact of this organization. So we have Miss Ingrid Laerdal, who's our Chief Impact Officer at Laerdal. As well, we'll be joined by Anna af Uglas, who is a midwife and team lead in the pre-services and solutions at LGH. So for those of you that got our emails, you might have noticed a different name. However, Anna was able to join us today, and we think her midwife background is such an amazing background really to bring to this episode. So we're really excited to speak with her.
Yeah, and I think she's going to really touch on like actually deployment of the equipment that she has done in the field. So I'm super excited about that.
Exactly. Moving on, we have some of the obstetric solutions that we'll do a little bit of an overview on, from MamaBirthie to MamaNathalie, MamaBreast. So these are a lot of the products you're going to see and we're going to talk about with Ingrid and Anna. And then following that, we'll dive into products like Prompt Flex, and then the demo that I think everybody is very excited to see with Shane. So what have you to tell us about this demo?
Yeah, so we're gonna do a live SimMom demo. Again, it's live, so this is gonna be fun. You know, like we're going to show you how to set up that SimMom, how to set up that ADM, discuss how we can actually position the baby, shoulder dystocia, show you where you can get references. So I'm super excited, but this is where I get to get a little bit greased up, and we get to work with SimMom and deliver some babies and cause some complications and get our teams working through it. After that, we're going to come back. We're going to talk about some hot topics, some new products out there, some improvements to the already existing products, as well as one of my favorite spots is because I always get the question, what version should I be on? So In the Know is a great place where we get to talk about any kind of new versions. What does that new version bring to the table, as well as some new conferences or anything coming up that we think that would be very vital, especially if it's related to the episode that we have. After that, we get to give free stuff. And that is also, it is like, soon as I hear free, you have my attention, but these are going to be free products that's going to help you, but it's also going to help someone else. And we're going to get into that. So stick around for that. You have to be present to claim the prize. So stick around, and we'll make sure. So when we draw a name, all you have to do is come into the chat, let us know you're here, and then we'll get your information so that we can get you the prizes.
Yeah.
And Clients Corner, Alyssa, what are we going to do there?
Clients Corner. This is for those of you that are longtime viewers or 3-season viewers. This is where you get to kind of network with your colleagues and ask us questions, or give us suggestions of things of how you deploy a sim program. Honestly, anything goes here as long as it's relating to sim, obviously. So we like to take this time to answer any questions, whether that be about software, about SimMom, about Simmon 3G Plus, SimBaby, really anything goes. And this is kind of your time. So feel free to join us on that session. We often, again, go a little bit over with this one, but these episodes are recorded, so you can always come back to watch the Clients Corner as you see fit with your schedule.
All right, so, I just wanted to drop one more second before we get to very special people. Keep on putting your name and where you're from in the chat. I am seeing some huge, very cool places. A lot of places in the US. We got Ethiopia. We have a client here from Ethiopia, Alaska, Illinois. So again, thank you so much for joining in. This brings a smile to our face, and hopefully it brings resources to your table. So thank you so much for joining in. We're so glad you're here. All right.
All right, now the very exciting part. We have two, again, very special guests with us today to come and talk about the mission and impact of LGH, which is Laerdal Global Health. So first up is our guest, Anna. Anna, do you want to introduce yourself to our audience today? Tell us a little bit about your background and how you came to LGH.
Thank you so much, Alyssa, and thank you also, Shane. It's a huge pleasure to be on board this webcast. I'm a midwife by profession since over 30 years, worked a lot clinically, delivering babies, but then also I went internationally in 2010. So I've been working in Bangladesh, and I'm happy to see there is a listener in from Bhutan, which was very close to Bangladesh, and then in Laos PDR for 3 years with the United Nations. I came to Laerdal Global Health 4.5 years ago now, and I've been working with the Laerdal Global Health products since my years back in Bangladesh. So it just came together when I went to Stavanger and started to work for Laerdal Global Health.
Amazing, thank you. And Ingrid, our Chief Impact Officer, I'll let you give a little bit of background. People might recognize your last name, but I'd still love to hear from you. So I'll let you introduce yourself.
Yes, hello, Alyssa and Shane and everybody on the line. Fantastic to see so many on the line and even an international audience. So that's super. I'm Ingrid Laerdal. I'm based in Stavanger in Norway, and I'm the Chief Impact Officer in our group. So what I do in that role is to support the teams working in our group with understanding and optimizing the impact potential of the different programs we work with. So when I talk about the group, it may not be obvious for everyone, so maybe I sent you a picture to help explain that very quickly, Alyssa.
I was going to say that Laerdal logo on beside your name looked different.
Yeah, it's slightly different, but also, I guess, recognizable, right? Yeah. But I think people on the line here would be fairly familiar with Laerdal Medical, the logo you see to the left there, which is our largest company by far, present in 25 countries and more through the distributors. But in addition to that, we also have Laerdal Foundation as part of our group. It's an independent organization, but we consider it as part of the group because it's working towards the same goal as the rest of us, and I'll come back to that. But the foundation is supporting practically oriented research in the areas we work with. And then today we'll talk about Laerdal Global Health, which is a not-for-profit company aiming to help save lives at birth in low-resource settings. And then finally, we also have the Million Lives Fund, which is a venture capital company that was established a couple of years ago, where we are investing in early startup companies and enabling technologies that also can support the Helping Save Lives goal. So the overall goal for us together with you is we've set a goal to help save 1 million more lives every year by 2030. And that's a huge number, and we believe it's fully achievable by working together and by focusing on the areas where there are huge life-saving opportunities, areas you work with every day. And in that 1 million lives context, the global health plays a very significant role, because there are, as probably many of you know, so many newborns and mothers still dying at birth, and most of these can be saved by relatively basic obstetric and newborn care. So that is what we're trying to support through our work in global health.
Yeah, that's very impactful. And I think a lot of our audience may not have known about the complexity of all these different organizations working together to one common goal. So thank you for sharing that, Ingrid. And if you don't mind, we'll start off with a question. If you could maybe tell us a little bit about how Laerdal Global Health came to be, and some of the programs and things maybe some of our audience haven't heard before. So I'll move on to the next slide, because I think there are some things you want to tell us about that.
Yeah, sure. So there are around 140 million babies that are born every year. And of those, around 5 to 10% need some help to start to breathe. And that's whether they're born in Tanzania, in Bangladesh, in Norway, or in the US. So babies are fairly similar in a way, whether they're born in a low or high income setting. But we have been collaborating with the American Academy of Pediatrics since the early 2000s on their newborn resuscitation program, and co-developing the newbie simulator for that purpose, and working on that program. And it was around 2008 they approached us and asked if we would be interested in collaborating on a program that was based on the NRP program, but simplified to really reach those health workers that are present where most babies die of birth asphyxia. Because even if it's the statistics I showed in the beginning here with sort of the common need in a way for newborn resuscitation and simple help to start to breathe, it's a fact that 99% of those dying die in low income settings. So there was a huge need, and there still is, to train health workers and birth attendants who are in low resource settings. And the NRP program is and was fantastic, and sort of the gold standard. And it was also used in more than 100 countries at the time. But it was, here you see some algorithms that some of you may know from ILCOR and WHO. And these are, of course, great, but they are fairly advanced and focusing on airway, breathing, compression, and drugs. And the American Academy of Pediatrics saw that it was possible to simplify and reach many more and help save many more lives if focusing only on airway and breathing, which is sufficient treatment if done soon enough for more than 90% of the babies. So that was a background, and it was just extremely meaningful to be part of trying to solve that challenge. So that led to the Helping Babies Breathe program, which was really a paradigm shift when it was launched. And this is, you see the action poster on the right-hand side here. And if you remember the algorithms from the previous page, you'll see it's much more easy to follow. You have it's a traffic color-coded, traffic light color-coded, so it's easier also to understand even for a health worker who may not be that good in reading, and it's also easier to remember. Mm-hmm. So this is focusing on the basics on airway and breathing, and using simulation training, which was also quite new, right? And really hands-on training to drill that golden minute and really get that sense of urgency into the participants. And one of the very powerful simulation exercises is actually in the beginning of this course. No simulators are involved, but people are asked to close their eyes. No, sorry, they're asked to hold their breath for a minute, just to experience that feeling, because it may not be the same relationship to time in some of these settings. And it's a very powerful exercise to understand the need to really act within this golden minute. So in addition to a training program and action posters and flip overs and solid educational design, we also supported by developing low cost and affordable simulator. You see the Natalie newborn simulator there. Mm-hmm. And also therapy equipment like a suction and a bag and mask, and offer that on a cost basis to support that this could be scaled up in large numbers. And importantly, also this led to the development of a global development alliance, very much led by USAID and including many partners, because many came along. And that led to that this program was implemented in 75 countries only 4 years after it was launched, and hundreds and thousands of birth attendants were trained with very good results on the outcomes. Wow. So this was sort of where it started, and for us quite a natural evolution from sort of newborn resuscitation program into this. Mm-hmm. But one of the lessons we learned very quickly was the importance of linking this also with obstetric care. And before this time, this was around 2010, we hadn't really done very much yet in sort of obstetric simulation and the whole birth process. But we saw and learned that there was an extremely important link, because so many of the asphyxiated babies could have been born healthy if the mother was cared for in a timely and good manner. And there is also the relationship that if the mother dies, the risk of the baby dying is twice as high. So this was sort of how it began, and what led to the development of the MamaNathalie birthing simulator, because the first program here was a program in helping birth attendants handle a postpartum hemorrhage, and there wasn't really a simulator solution. So that's the backstory to how all this started.
Amazing, thank you.
It is amazing, thank you.
Yeah, it's very impactful, and I don't know if some of our audience has any questions, but if I'm sure there's some people that this is completely new information to, and we love sharing the story because, and hearing it too, it's very impactful.
Yeah, we got some messages in the chat. MamaNathalie has really helped our healthcare workers to save women. It is very important and effective training to save all ill survival lives. So a lot of people dropping little messages, and these are people, no doubt, that are using these in their facilities. Whether or not it's low resource versus high resource, it's impactful. So, and we're going to get more into those products now after that.
We will.
Thank you.
I believe we have a video that we wanted to share. I don't know if Ingrid, you had anything to say prior to watching it, or I know we'll get into it a little bit after, but in case you wanted.
Yeah, so now I talk more to how did this begin, and this video that we'll like to show now is I think it's a 2-minute video, and it gives an update on where are we with these programs today and what are some of the focus areas. So let's have a look.
Perfect.
Ange-Marie gave birth to her first child, a baby girl, Gianna. But soon after the birth, Ange-Marie began to bleed heavily. Her midwife, Gentile, trains regularly on the Helping Mothers Survive programs, and she knew exactly what to do. Ange-Marie survived. But not all mothers are so fortunate. Every year, 300,000 mothers and more than 2.5 million newborns die from birth complications. Before the pandemic, this was improving. But because of disruptions to healthcare systems, for every person who's died from COVID-19, 2 women and children have lost their lives. Together with our partners, we're focused on making the biggest impact. A key initiative is the Safer Births Bundle of Care, supported by the Tanzanian government and the Global Financing Facility, a division of the World Bank. It will be scaled up in Tanzania, covering 1/3 of the population. That means 500,000 safer births. In Ethiopia, the Saving Little Lives program, aimed at premature newborns, will roll out in nearly 300 hospitals, covering almost 1.5 million births every year. So far, more than 1 million healthcare workers have been trained in the Helping Mothers and Babies Survive programs. But when the pandemic hit and face-to-face learning was put on hold, we had to find a solution. So, together with the American Academy of Pediatrics, JPIGO, and the World Health Organization, we've been adapting our programs, making them digital and available online as a global good. And we're just getting started. We aim to inspire other countries, other private and public organizations to join us, to work towards our goal of helping save 1 million more lives, together.
Oh my, those babies.
I know, they're so cute.
Unreal. I seen some really neat, like I think it's called the Neo Beat.
Yeah.
Goes around. I'd love to hear more about that. That's so cool.
Mhm.
Yeah, it's an incredible life-saving tool for sure.
Yeah, I think we might hear a story about that in a little bit. And I mean, as a jump off of this video that we just watched, I think some of us might be familiar with some of the programs that we have in place, such as Helping Babies Breathe or Helping Mothers Survive. Can you tell us a little bit more about this, Anna?
Absolutely, very happy to do so. Building on what Ingrid have shared with us and building also on the video that we just saw, the Helping Babies Survive and Helping Mothers Survive programs have been super pivotal in our and our partners' work in the low resource settings. The programs have been implemented in over 80 countries and given the consequences after the pandemic now, where a lot of training have been halted because people cannot travel or meet, that the programs are really more important than ever at this stage. We are ranging from the full, from before labor, through labor and birth, and into the newborn resuscitation and essential care for every baby. So we really want to cover the full continuum of care for mothers and babies. The programs are based on a blended learning approach, meaning that it is knowledge, but also a lot of skills training. So when you undertake one of the programs or the programs together, you really practice a lot, which means that you as a healthcare provider, you keep on developing your competencies by training, but also more importantly, to move it into the facility, because that's really where we see the change of care. So I think you can go into the next slide, Alyssa, because what we saw as a consequence of the pandemic, our colleagues out there, they couldn't practice and they couldn't train as before the pandemic. So as we said also in the video now, we added on the digital solution. So you are able to actually remotely train people. Here, I'm training colleagues in Khost, which is a very remote area in Afghanistan. And it's Doctors Without Borders who see a huge need of newborn resuscitation. So they got the mannequins in Khost and they got the materials physically, but we also had them digitally. So we were able to sit and train from afar with local facilitators in place. And that was amazing experience, I have to say. But it is not enough with training. So going to the next picture, we learned from the beginning, we did the training, and working with the UN before, I know a lot about training, and then the midwives, doctors and nurses go back to their clinics and not much happens, and the learning, it's great for the day, but then it stops. So if you go to the next one, what we really learned from implementing the Helping Mothers Survive and Helping Babies Survive programs together with our partners, that's really important. We learned that changing from training to keep on practicing in the facilities, that was what really changed the behavior of midwives, nurses and doctors, but also improved the performance. So we saw astonishing results if the healthcare providers were able to keep on practicing with between 40 to 80 reduction in newborn deaths, and even so 25% reduction in fresh stillbirths. And that is amazing results. And as a healthcare provider, you have to keep on practice. It's a skill that's in your hands, and you have to keep on practice in the facility. So that was really a strong lessons learned from our side.
Wow, yeah, these numbers are very, I mean, jarring, but it's beautiful to see that they have increased, or actually in this case, reduced the newborn mortality and stillbirths. So that's such a nice thing to hear, and that the program is successful, and that we can keep working for better outcomes. And I love to see this. And I actually had another question kind of relating to this, I would say. Is there anything we can expect in terms of, you know, what's next with the programs or products, things like that?
Absolutely. We are building on what we have learned. We are building on our partnerships. We're building on what we hear from our colleagues out there. And some of you I see are in the chat as well. That's wonderful. We will continue to digitalize the Helping Mothers Survive and Helping Babies Survive programs together with our partners such as JPIGA and AAP. But what we also have done recently, our designers have, in collaboration with surgeons, developed a C-section module for the MamaBirthie. And that came from a Lancet series publications on the enormously globally challenging amount of high C-section rates to address that, because it's harmful for women and their newborns when C-sections are performed and they're not medically indicated. So the MamaBirthie C-section is a new coming model. We have piloted in Tanzania and Ethiopia with very positive results. You see me as a standard patient here. This was in Tanzania a few months back only, where the anesthesiologist and the obstetrician really had a good chance to work together as a team. So that is something that is very important to actually emphasize the teamwork. But also you see the anesthesiologist is talking to me, and then also point out the importance of respectful care and communication. And then, of course, the importance around decision-making around C-sections, so that the women who need C-sections gets it.
Wow, amazing. And I don't know if there's any questions in the chat, Shane, but you can always pause me if there are.
Yeah, no, there is a question there from Anna. Anna, they are planning to roll out an impact assessment in their country. They're wondering if you have any structured questionnaire that can be used. And so I'll leave that one for you to answer once we get into the other material, but that question is there. So again, we're monitoring the chat. So any questions, Anna and Ingrid are gonna stick around. So if there's any questions, just feel free to message directly to the panelists, and they'll get back to you now when they go offline here.
Awesome. Well, thank you. Thank you for the questions, and keep them coming. I think one of the last questions that Shane and I wanted to ask about is there any lessons or learnings that you feel can translate from these specific scenarios and settings that we can bring into potentially high income settings that you mentioned?
Sure, I can maybe start. There is fantastic amount of research around these programs, and I don't even know the exact number, but there are more than 100 papers that have been published, and they are focusing on sort of two categories. One is research around the more physiological changes, what actually happens when a baby is transitioning from being a fetus to a breathing newborn. There were so many, and still are many questions about that transition that we don't really know the answers to. But through this, over the past 10 years, there's been a lot of research, for example, on, you would think, simple things like how long time, how many seconds does it normally take from a baby is born until it starts to breathe? What is actually the heart rate of a baby that needs resuscitation? The guidelines say if it's below 100, then it's a baby that needs resuscitation. The data looks quite different when you actually get the data from newborns. So already there have been research coming from these programs that have influenced the global guidelines, and in that way are already now influencing how babies, even in the US, are being cared for, because that translates into the US and international guidelines. So that's one side of it. And the other big focus area have been the implementation research, to really understand what are the factors that needs to be in place for these programs to really have a significant impact. And we know that when they're well implemented, we have data that for every person trained, one more life, and actually in some cases up to 2 more lives can be saved every year per person trained. And if you think about the number, the thousands and maybe millions of birth attendants that needs to be trained, that says something about the impact potential. But we've also learned, and I think these are the points that sort of translates to also high income settings. We've learned that for this to really have an impact, it needs to be implemented on a low dose high frequency model, and very importantly also in a quality improvement approach, so that you keep on measuring and improving. So it doesn't change anything if it's a one-time training, as Anna pointed out, but if it's implemented in this quality improvement, we see fantastic results.
Amazing.
Awesome.
Thank you.
Can I add?
Yes,
Yeah,
please.
can I add a little bit to that too? Because we are looking also more into pre-service education, meaning nursing, midwifery, and medical education, where we see that the Laerdal Medical and Laerdal Global Health products really fit and complement each other. One example is the one university in Finland who started to use MamaBirthie a lot in combination with their high fidelity simulators to train more midwives in the same group. So they had a chance to practice much more with a MamaBirthie as an add-on to the high fidelity simulator that they had. So we have other solutions coming up also that has been developed or even tested in low resource settings that is definitely highly needed in the high income and vice versa. So we see the world coming together more and more as one. Midwifery education faces the same challenges with faculty, with the access to the simulation labs for students, access to clinical facilities to do that practice and so forth. So we're really talking with a global voice more and more, and I welcome that. I think that's very exciting.
Amazing. I mean, I wanted to thank you both so much for joining us on this episode. And again, if anyone has questions for Anna and Ingrid, please feel free to put them in the chat or the Q&A. We are lucky enough to have them stay on with us for the rest of the time and kind of take a peek at your questions and hopefully answer them, or maybe reach out with more information at a later time. But again, they will be in the background with us, so feel free to continue your questions. And with that, Shane, I know we have some fun things to talk about, kind of, again, bringing in what we just saw with Ingrid and Anna, but I guess a bit of a deeper dive in terms of what these products do from, more of a feature set perspective and how you can use them.
And I know one thing that they had on their slide there was all about the BOGO program. So you buy one and gift one, and we're going to talk about that more and more, where you buy a MamaBirthie, and we actually give a MamaBirthie to a low resource income country or a low resource country, where they're having these morbidity, mortality around maternal and fetal or babies. So when we're talking BOGO, that's what we're talking about. You buy a SimMom, it comes with a MamaBirthie, but then they also give a MamaBirthie away. So we're going to talk about that impact as well a little bit as we go. But so yeah, the MamaBirthie, what can you tell us about that, Alyssa?
So MamaBirthie is a really great way to get your learners comfortable with, before bringing them to SimMom that we're going to see in a bit. This is a great product to use for kind of, as they mentioned, task training, but also team training. You could do a lot of rapid cycle deliberate practice. It's an easy setup. You can have as you see in the photos, a standardized patient. You can have it kind of on a tabletop. So it's very flexible, but offers also a lot of really nice features in terms of assessing fetal positioning, vaginal examinations with cervical inserts and simulated membranes. So you really don't just get kind of, I guess, what you see on the screen. There are a lot of extra components that come with it, and we'll see that later on. But you do gain a lot of tactile feedback during, I guess, positions like shoulder dystocia for baby birthie's neck flexion. You can also evaluate high-risk births, including breech, cord prolapse, and partial placenta delivery. We actually also added, you'll see this a lot in our slides, a QR code that brings you to either more information pages or video pages that talk a little bit more about the products if you have this and you haven't yet used it. As Shane mentioned, this product is a part of our BOGO program, and specifically in our Obstetric Solutions, when you buy a SimMom, you actually get a MamaBirthie. And a lot of our customers that Shane and I have spoken to didn't even realize maybe how to, set it up, how to use it, what it exactly is for. It kind of comes in a backpack, but it's
they thought it was a really cool backpack, and they opened it up and they're like,
it's not just a really cool backpack. It's a really, really cool backpack that has MamaBirthie inside. So pay attention for that. If you have a SimMom or a SimMom coming, you are getting one of these. And as a part of that, you are also helping the impact of LGH by the donation to a country in a low resource setting. So keep that in mind. And then Shane, we also have MamaNathalie. So some of you might have heard of MamaNathalie. She brings in a lot of interesting features as well. And one of the main things that differentiates her is the set of wet skills and being able to do postpartum hemorrhage scenarios with her. So Shane, I know you might have had something you wanted to mention here before.
Yeah, and I think you hit a nail on the head. I mean, when we go back to MamaBirthie, we're going to talk a lot about the positioning of the baby. The baby has a little bit more fidelity to it in regards to fontanelles and suture lines and positioning of the baby. This one's adding the mom care. This is adding the PPH. This is adding uterine bladder catheterization. So anything that you're thinking about the wet skills, this is more so so that you can get realistic bleeding. You can get uterine massage for an atonic or contracted uterus. And you can actually control that uterine firmness so that you can get your practitioners, noticing the difference between an atonic and tonic uterus. So realistic bleeding. And again, it's deliberate cycle practice. This does not take long to reset and go again. SimMom is a little bit more tedious. But again, this is for rapid cycle, deliberate training. I even have clients in even my small part of the woods here where they actually use MamaBirthie first, move from MamaBirthie, go to SimMom. or vice versa. They go from MamaNathalie PPH scenario into a SimMom PPH scenario. So this would be more skills, and then they can move into more scenario, or you can do scenarios right with this. So it depends on what kind of resources you have and what kind of resources you want to give to your practitioners to be able to get that tactile, but yet didactic, but yet corrective information that we can lead to better outcomes. So
well said. Yeah, exactly. And also another one that often gets forgotten about, that people might not know that we have, is the Mama Breast. So this is a great breastfeeding, positioning, and attachment trainer. You can express simulated breast milk, not real breast milk. And it's an excellent addition to the maternity and neonatal training programs. I think in the previous picture, you can't really see it, but a lot of times you might even see this paired with a MamaBirthie or a MamaNathalie on a standardized patient. So we just wanted to make sure that everyone kind of knew about it. And I know, Shane, you have an example of a customer that was looking for something like this and didn't even know we made it. So
yeah, no, and it's probably one of the little hidden secrets coming from our mama family. I just asked the question because I see a lot of male nurses, and I see a lot of just situations, and I was just like, well, how do you train lactation? And they were like, well, you know, the honest truth came out, and it didn't seem like they desired that. And so I showed them this product, and you know, this is a very affordable and a very easy product to use. And when we're talking about simulated breast milk, it's sometimes just as simple as water.
Yep.
It's very easy to fill, and it's using the correct, you know, you can get the right kind of expression. So yeah. Perfect. So Mama Breast is it was one that actually I didn't even know about, and I seen it in the field, and I'm like, oh, who makes, oh, we do. So that was that's why we wanted to add it in here. So for your nursing programs, this would be really fall nice in accreditation purposes and showing how you accomplish this. So the next step up is Prompt Flex. So Prompt Flex is like the bottom part of SimMom. So it's just the torso, and you can get it with the stubbed legs or the amputated legs or the half legs, whatever you want to call it. But we also have the long legs as well that you can put on this. So just to let you know that that is an option. So this is ideal for addressing high risk, low frequency events and reducing complications. So Prompt Flex, if you go all the way to the right or all the way to the left, it comes in 2 skin tones. And this is the basics of the Prompt Flex. And then you have add-on modules in between. So if you go from the left and move over to the one, you'll see the cervical dilation and effacement module. Fantastic, works great. I get great feedback when I set this up, and I have midwives and students and everybody assessing, because not only can you talk about cervical ripeness, you can talk about the opening, and also then the presentation of the baby. You can see all the different, you can have a face frontal, OP, OA. You can even have a breech where it's the cervical opening is just covering the bum. And this is how my little girl came into the world. And I can tell some funny stories around that, but because you know, when we start to talk about tocos and little clips that go on the head that we can see baby's heart rate, well, that ended up on her bum and not on her head. But again, this is a great tool for applying that. The next one over is the Pph module. This is a very, very affordable solution that can go inside of this Prompt Flex. So all these modules go inside of these Prompt Flexes. But the Pph module, we have a Prompt Flex advanced presentation QR code right over there. This is a presentation that I made up for fine folks in the USA, where they actually bought a Prompt Flex advanced, and we did a series of videos to teach them how to use it. So feel free to take a gander over there. The Pph module and how to set it up is there. Also give us your feedback. You like it, you don't like it, you want to, you know, you want to see something different, that's what it's there for. And then the next one over is the C-section module that can come with the Prompt Flex. So again, delivering those kind of learning objectives to your teams is applicable here. So yeah, so the advanced option versus the standard option. The advanced option gives you force feedback in newtons on the baby's head. It's also, you can apply some scenarios to the Prompt Flex so that you can have a standardized patient, or you can just have a scenario being generated from this where you can actually put in annotations of when activities are taking place. So that's the Prompt Flex.
Amazing. Thank you,
Available
Shane.
through Laerdal. Yeah.
And yes, big shout out to that QR code. If you want to watch this recording again, it's a great presentation, so highly recommend. But now we've made our way to the exciting SimMom live demo. So Shane, I know you gotta get over to
take off if you want to.
Yeah,
if you want to talk them through what we're going to do.
Yeah, I'll walk everyone through what we're going to look at, what we're going to do here. So as Shane moves over to the other lab, we're going to look at loading the SimBaby, or sorry, not SimBaby, that would be a lot of work. The baby of SimMom into the automatic delivery module. If you don't have this with your SimMom, this will be really great information for you to know. If you do have it, maybe you'll learn something new. We also added the QR code for the how-to videos in case you wanted to get those in your training curriculum. We also have different positions that we're going to look at with SimMom's baby, as well as how we install shoulder dystocia scenarios. We'll look at setting up the postpartum hemorrhage module. We get a lot of questions about this, so we're going to talk about that, how we look at getting the retained placenta and inverted uterus modules as well. And then finally, we'll look at basic LEAP scenarios, how to operate the ADM within LEAP, looking at contractions, things like EFM setup. So a lot of stuff we're going to be able to look at. And before I pass you off to Shane, we did also add in the SonoSim early and late stages of pregnancy scenarios. So if you want to know what those scenarios actually are, you can take a look at these QR codes. Again, this is recorded. I know we go fast through these slides, so if you didn't
and the QR codes, just to kind of point it out, Alyssa, how am I sounding on your end there now? Are you able to hear me?
Great. You're sounding great.
Perfect. Okay.
Yeah.
So the QR codes, this is actually mostly designed for your phone. So you just take your camera and kind of hover over it. We really started to like these because in COVID situations, when you go into a restaurant or go somewhere and you want to look at a menu, instead of passing you something that was full of COVID, they just get you to kind of scan this QR code and bring up the menu. So if you're having problems with the QR codes, it's mostly phone driven. And if it's not working on your phone, drop us an email, hsl@laerdal.com, and we'd be happy to send you the link to where these are supposed to be taking you. So I know that you just covered the early and late stages. The other thing that we wanted to bring to the table that is going to be a little bit more time, I'm going to get you into the ADM and I'm going to get you into the Pph first. But there's also ability. We're going to be broadcasting our EFM out to a virtual monitor, and I'm going to show you pictures of that as well. But there is abilities for us to take that information coming from your LEAP and its abilities to push it out to your actual clinical TOCO. So you're actually able to use your real clinical TOCO from the LEAP and push it over via this VitalsBridge FM. So this is a new lineup, probably came out about a year and a half ago, where VitalsBridge seen a gap and said, well, we're not able to communicate with TOCO machines and to be able to get variability and tonus. So we're going to create this. So just in case we don't get to mention it inside the demo, there is the QR code for it right there.
Awesome. Well, I'm actually going to stop sharing and we'll see if we can highlight you, Mr. Petal, so that everyone can see some big.
There we go. Excellent. So during this part of the presentation, I'm going to show you how to load the baby inside the ADM. And I'm going to be able to switch over between this camera. I also got this camera here as well so that we can actually see down inside when I go to change anything out. And we also have our patient monitor hanging out over here. So, so for right now, what I'm going to do is I've already used my SimMom, and here's some of the tips and tricks that we love to bring to this show. Is that I have my SimMom lube right here, so I'm going to have that ready to go. I also have a water squirting bottle. The thing why I like to bring this is that this lube is water based. So after time, it'll actually dehydrate. So I've already lubed up my baby But now it's been a half hour and the lube is almost kind of sticky. Now, what can I do? I can always take lube and I can apply more lube. I'm going to be not using gloves today just so that I can give you a little bit more insider look of what's going on here. But I'm going to use my lube. Now, if I use this lube and I birth the baby and I want to go right back into another scenario, you can use this little misting bottle and that will actually reconstitute some of the lube. So right now, Alyssa, I'm being a horrible salesperson because I'm not selling you more and more lube. But again, our job here at Laerdal is to help save some lives and not sell you more lube. So that's just my little takeaway right away is have a little water bottle. The other thing that I like to have is I'll have a water bottle as well, but I'll fill this one with some simulated blood.
Nice.
And I'll do that because I'll spray that on the baby. And so that when the baby's born, we have some realistic kind of features that are coming our way. Now, what else do I lube? Now, I lube, this is the baby kind of base. This is really important to lube up, especially like where you're going to put the little feet, because they can get stuck in there pretty good. The other things to lube is inside the ADM where the baby is going to be sliding. Mm-hmm. Inside the mom's uterus down here, and the external birth canal as well. I'm going to lube that up nicely. I'm then going to take my base and I'm also going to lube up the inside of this ADM casing. And I do that because it's just another place for everything to stick to. And again, I already had some lube on it. I could have just threw a little bit of water on there and that would make this all a very slippery surface. Now the baby, you can position the baby OP, OA, breech, and there's also a shoulder dystocia when you're using the ADM. The first thing I'm going to do is I'm going to do an an OA presentation. So I'm going to put the baby in and I'm just going to have him sitting there just like that. So he sits inside of this. So let's flip over the camera here so that we can see it a little bit. So the baby, I just put his feet in and then his little bum just sits right down in there, or her bum or non-binary bum sits right down in there. When we're ready to load, you want to make sure that you load the head in first. And it's the same thing if I wanted to go OP versus OA. Mm-hmm. And I actually going to share another little trick that I do with a lot of my simulations. Is I'll just take this little blood bottle and I'll put a little bit down in the base right here. And I find that will also help with the simulation in regards to creating a little bit of realism around some of the fluids that might be incorporated with birth. Here we go. So
do you mind if I ask you a question?
Sure, all about questions.
So
I'm going to fit the baby right behind the bellows so you can see that this fits right in the bellows. Now we're ready for your question.
Yes, and I think it's a perfect time just because you're handling the umbilical cord right now, but we had a question about at times the umbilical cord gets caught in open channels and damages. Is there any pointers of how to avoid that?
Yeah, that's a fantastic question because I've had that happen. What I suggest is go right back to the user manual and it will tell you kind of where to tuck the umbilicus and the placenta. So when the baby is OA like this, it's best to put the placenta and the umbilical cord right on the side. Another thing that you could do, because you can imagine now this umbilicus is pretty long, is that we can do nuchal cord, we can do cord previa, where it actually becomes clamped. But I find the best place that it doesn't get caught up is right on the baby's side, right inside this little nook cranny right here. I can put it on this side here so the camera can pick it up a little bit better. But I find that the less that is tangled around where the base is, the better it will be. So just on the side, but great question. Once I have that positioned in there, I'm then going to take my cover. And again, this is where it could nip. But as long as you got these two lower tabs lined up and the two upper tabs lined up, you should be able to click that down nicely. And I'm just going to pull her shirt just a little bit out of there. So that clicks down into there. I just had these removed. These here are actually supposed to be in place. I was removing this because I was going back and forth between the Pph and the ADM. And we're going to show you that switch as well. It doesn't take long, especially when you have a little bit of practice at it. But of course, my fingers are all lubed up. There we go. Now, I'm going to leave the cover off, but remember that the SimMom belly just goes over top. And don't forget your 3mm jack line that could go in here, and that's to get baby's fetal heart rate and be able to hear it. We can also adjust that fetal heart rate so that you're actually hearing mom's GI sounds as well. So we can do that. Yeah. Now, let me just use my towel. And we can, yeah, have lots of towels and lots of OB pads around. That's always good benefit. But here you can actually see how I can, inside of the Leap software, I can tell it which one I want it to be. So occiput anterior, occiput posterior, breech, and shoulder dystocia. So right now we have an occiput anterior, and it gives you instructions on where to lube. So anytime you see like this little star, you can see, you see there's some stars here, there's some stars here, there's some stars on the placenta. You can see how we're loading the baby in head first and then continuing on. Now, we can also add Efm history. This would be really good if, you know, you have a obstetrical triage area where the mom might have been triaged for the last 30 minutes and you wanted to add 30 minutes of history. So you can add anywhere from 1 minute right up to 60 minutes of Efm history so that you can start to look at things like the fetal heart rate pattern, the rate, and variability. So here you can see you can change the variability and also put in early decelerations, episodic accelerations, sinusoid. So you can see all the different things here that you can add to get some more history on what mom is doing as well as what baby is doing. So for this one, we're just going to say that we're going to continue without Efm history, and that will start to load my mom. And just like on other occasions, we can always edit before starting, or we can hit start session. So edit before starting gets us to this screen where we can actually start to edit mom's vitals and have that ready to go. But the other thing that is, we can also set up the automatic delivery setup. So right now, by default, she's not in labor. We can go in labor, and these are all ratios in time. So 10-10 means one contraction every minute versus 2-10, one contraction every 5 minutes. And you can see that they all increase. So I'm going to put her at 10-10, one contraction every minute, and we're going to get this baby to deliver in 2 contractions. And we can hit start ADM. So ADM will start now once I hit start on my Leap instructor control PC. So you can see that I'm still paused, but I'm ready to play. The other thing I might want to do is I might want to change my patient monitor. This patient monitor is a 5-wave. That's pretty serious. That's you know, someone with wedge pressures and all that. It's not typical for your obs to have, you know, arterial blood pressure and all that kind of nice stuff. So we can actually change that. We can just bring it down to either a big number or a 3-wave and just change that monitor. The other thing that I love to do is I can toggle my EFM. So right now I can see that I can make my EFM really big, or I can toggle it again and actually have the EFM just below my vital signs. So, so you can just play with that to get an idea. But I'm going to hit play now and have mom deliver this little one. So she's going to have 2 contractions. So on our EFM down below, we're going to see the mom's contractions. I don't think we have any marked variability. I'm going to put up a couple of vital signs here, and we're also going to do a blood pressure, just so that we have that up there. And Ready, and we're just there's a push going on right there. You can see the contraction coming in on the EFM, and we'll just go over here so that you can. So there she had a contraction. We could have SimMom now with the vocal sound. So if I were to go back over to the IPC, we can go over to the vocal sounds where we can actually get some pushing. So she can actually have some vocal to go along with this. All right, and we can go back over to the patient monitor again. Oh, it looks like we are frozen on SimMom. There we go. All right, here comes the second push. So I'm just clearing a little bit away. Now, if I had an obstetrical bed now, this would be a good time. I've seen a little bit of cord here now. If I drop my bed now, I can deliver that anterior shoulder. There's no compression on the cord. And out comes the little tiny baby. And there we go. We can see a little bit of the simulation coming out on the baby. She has delivered the baby, and now we can apply. We can put in when you get SimMom, she comes with these tubes that are clear that you can clamp and then cut, so that then that doesn't become an issue. But we can be clear and free of the baby. And this is one of the things that I love about SimMom. This baby comes out with no fidelity, but again, for your rapid cycle or deliberate training, this baby can actually be thrown into a sink with some mild soapy water, come out, and he's all clean. So a lot of SimMom cleaning is very easy. And that's one thing I love about her, is that she's very easy to clean and get ready for our next simulation. So if we wanted to do OA, OP, or shoulder dystocia, it's all done with this base. The second that we want to do breech, we actually do breech without the base. So breech is actually done with just baby sitting in here without the base. And the bellows, when we go to shoulder dystocia, is actually designed to give more pressure to get this baby through the birth canal and out. So that is one of the biggest things. The other thing that I'd really like to talk about before I take down the ADM and go over to the postpartum hemorrhage is that if we were to go over to the IPC and stop, we're going to start a new one. We're going to go manual mode, healthy patient, yes. Here is something very key to remember, is that click on shoulder dystocia. And this is where a lot of the times our end users have a lot of trouble, is because of this little cable that goes onto the baby's leg, hip area. So you can see that this is what it looks like right here. There's a pre-tied knot in the top. And it's how that hooks around the baby and then goes down and up through. There's a little tiny notch right in here, right in there. And this string actually goes down and around and back up through. And you can see that in the instructions right here. You can see it going down and then up through, but then when you go over here, it shows you how to load it and then how to tie it to the top side of the ADM. So this is where it's going to tie in, is up here, right on the top where there is springs. And these two springs, what they allow is that the baby is allowed to be propelled through the birth canal, and then you get the turtle sign where the springs will then try to pull the baby back once the bellows have deflated. And that will give you that really nice healthcare practitioner trigger of turtle sign, where they're going to start activating their also course, including, subcubic pressure, rolling on all fours, wood screw, and all those medical procedures that we're looking for to help get this baby out from shoulder dystocia.
Shane,
So
I have a question, if you don't mind.
Yeah.
Well, first off, I just wanted to say, I know it is 5 minutes past the hour and some of you had to jump off. We are recording, so we will be sending this to you. Don't worry about that. All our registrants do get a recording, but just an FYI. And our question, Shane, can you actually show us where exactly do we place the string on the back of the ADM? We have someone who has had a little bit of issues with that, and it can be tricky. And I know you're talking about it, so maybe, I don't know if you can show us from the up view.
Here, let me try to see if I can. Wow, this episode went really, really fast.
I know.
I was wondering if we should, before getting into the PPH, if we should do the BOGO, if we should do the free.
Oh, the giveaway?
Yeah, just because I don't want people to have to leave and they were looking forward to.
That's true.
Yeah. Let me see if I can adjust this camera. There we go. So let's go front cam. So where this string, so this part of the string, this one right here, is going to be going around the baby's hip. And then the string comes up, and so this plastic part goes over the hip, and then it comes down in through here and goes into this hook that's on this wheel.
Yeah.
So you can see that wheel there. And then this little knot goes into this little slot right here. There's a little, this is an ECG line. Let me just pull that up here. So this knot fits in this slot. And then what I usually do is I give it a good pull, and that secures that knot into that slot. The other thing that you need to be really aware of is that there's this little yellow line right here. And that yellow line goes right into the compressor right below the ADM. Here, I got my camera falling and everything. It's perfectly timed. Here, let me see if I can, let's flip you over to here. And so I can adjust this. Let's see if I can get a shot of that. No, it's
That's
no.
okay. I think that, well, we got to thank you so much. So I think we got
Okay.
The point was really that cord placement. So I think that was perfect. So did you want to, we can head over to the giveaway, Shane.
Why don't you start the giveaway? And I'm going to, while the giveaway is happening, I was going to set up the PPH. But yeah, let's go through the giveaway, and then we'll come back. And if we don't get time in this episode, we will record setting the Pph module up from the ADM and give you that as a resource as well. So I'm going to head back on over.
Okay, perfect. And I will share my screen. So for those of you that are still with us, thank you. And you get to be luckily a part of our giveaway. So I will just share my screen. And so what we actually have for you today is a MamaBirthie, and we're very BOGO program. We also thought this would be a really nice way to, you know, one give one, but in this case, it's the give one and a gift one in a way.
Yeah, so it's
So
a win
do you
one,
guys
gift
still
one.
see my screen?
You get to win, and we get to give one.
Yes, and I actually have one of the winning products with me right now. So this is MamaBirthie, and for those your from your SimMom delivery, this is what she looks like. But on the inside, so please keep an eye on that. Oh, am I still sharing?
Yeah, no, your video was frozen there for a second, but I think we got the concept. So you got a MamaBirthie there to give away. So
Yes.
This is actually the one we're given.
This is one of them, yes. So I just wanted to quickly open this for you guys. So you can actually see that there is in fact a product in here, and it's the one that we saw today. So just for you guys to know a little bit more. But heading over, do we see the Wheel of Fortune on my screen?
We do. We
Perfect.
do.
All right. So what we're going to do is we're going to actually draw a name. And if you're present with us, drop us in the chat that you're present and we will take note of it and reach out
Big
to
money,
you.
big money, big money, big money.
Jessica. So if you're here, just
Oh,
drop in the notes that you're present and we can always roll again if the person is not here. So you can let me know, Shane, if in
yeah,
10
I'm
seconds
watching the
now.
chat, seeing if
He is
Jessica.
there.
He's there?
Yeah.
Amazing. Okay, well, congrats. We're happy
Jessica,
to
we
send
were
you-
talking earlier today.
Oh, really? No way.
Oh, wait. Is she there? Look
Oh,
in
I haven't
the
seen her.
chat.
Oh, Jessica might have had to drop off. See, this is why I wanted to get this wheel turning.
All right, we're gonna do another one.
Let's do another one.
Okay.
I'll keep on watching for her.
And if
There are
not,
a lot
we
of
might.
interested participants.
Yeah, there's a lot of people saying they're here. Patricia Campbell.
Do we have a
are you
Patricia?
here? Patricia.
And if not, we can always do a pop quiz question to see if you guys were listening to Shane with the remaining.
No,
People.
Patricia's not here. So people are putting that they are here. So hopefully we'll come across a name that's here.
Wonderful
have
to see the
everybody's
interest, huh?
Yeah. Cecilia Weaning. Oh, Jess is here. Jess is here. So you're there with, there with Renee. Okay, she is having trouble. Okay, so I think Jess wins. Jess definitely wins. But Alyssa, we have one winner, and we're giving one away to a low resource country. Let's do two. Let's
Yeah,
give away
why
another
not?
one.
Let's do two. Let's do another one, and then
Yeah.
we can give two away. So we have Jessica confirmed for
Yes.
one.
Yeah.
Amazing. Congrats. And let's see who we can get for the second one.
Mhm.
Suspense.
Patricia.
Another Patricia. Do we have Patricia Bingham?
Patricia, are you still here?
Yeah.
She's here? Amazing.
Oh, there she is. Yep, we have our two
Congrats.
winners. Congratulations. That is awesome. We will make
win.
sure that we will get a hold to you by email and get some mailing addresses so that we can get our MamaBirthie to you. And then our other two MamaBirthies will be going to low resource settings to help save lives over there. So
Yes.
that is super exciting. Thank
Shane,
you
if
so
you
much.
don't mind, I'll talk a little bit about some of the upcoming webinars we have. And then you can head over and we can finish the demo if you'd like.
Yeah, that's absolutely, yep, that works great. So if you can stick around, I will head back over to do the Pph demo. But first, we want to let you know about more obstetrical conferences or meetings or webinars or webcasts or podcasts that are out there. So let's see what those are.
Yes. So the first one that we wanted to let you know about is the webinar that's happening on March 4th at noon Eastern Standard Time. So this one is, again, we wanted to kind of bring to you anything that related as well to obstetrics. This one is called Accelerating Competence and Confidence in Obstetric Emergencies. We also added the QR code here for the register now. This is with guest speaker, Dr. Peter Nielsen. So if you wanted to register, we have that link there. But again, we will refer back to this in the recording so you can watch it over again. And then following this one is our virtual sun, which is with special guest Dr. Roxanne Gardner. And this one is again around OB, but this time it is entitled OB Claims High, Make Sim Your Best Defense. So this one is on March 17th at 2 p.m. Eastern Standard Time. And again, we included the QR code if you were interested in registering. I know some of you are on your phone watching this episode, but again, the recording will have all of these links. So feel free to stay tuned on that. And with that, Shane, I don't know if you had.
Can we
any
just go over
specific-
the in the know really quickly, Alyssa? I know we're jumping around here a little bit, but just to
Oh,
get you a little
yes.
bit in the know. So anybody that's with us today, you know, those future people, you might want to get a more just look at the website to find out what the number is. But as of today's date, the SimPad Classic yellow button, remember, you can only go to 7.4.5. And then the leap that you're going to use with a link box that is a classic link box is going to be a 7.3. So just make sure that if you have newer equipment and you upgraded your leap, remember some of your older equipment might not be able to use that new leap. So just let your CE know, let your client executive know, give tech support a call, give us an email. We'll be able to help you out with that. SimPad Plus is now in version 8.1. This is a pretty new version. So just in case you might be on 8.0.1. So if you have dyslexia, it might cause some complications there. But the numbering convention now is 8.1.0. Also reminder that if you use Theme Editor for building your themes for your SimPads, there is a new theme editor as of last year. Silverlight was discontinued. We had to change the way the theme editor works. So now it's on 1.3. So you're going to have to uninstall or delete your previous theme editor and install this new one. Leap is on version 8.1.0. Some of the new stuff that brings to the table, SimMan 3G Plus can now be used as a virtual mannequin. So it's really good for practicing your SimMan 3G Plus from home, from the plane, from the ship, or anywhere else that you want to practice your IPC skills. There's also new pulse control on SimMom too. So there was a little bit of a bug there that her pulse wasn't really working really nicely. So they fixed that. Our fantastic Denmark team fixed that for us. And then last but not least is how-to videos. I just wanted to bring this to the forefront again to let everybody know that we do have resources for you for videos, not only your HSL webcasts, but how-to videos coming directly from professional production, like where Alyssa is now at the link, giving you really good insight on how to use our products and how to use them better or more efficiently. So those are there. Also, the HSL webcast is available on your resource library on your Laerdal.com website. So inside the resource library, we are located there. We're also on YouTube and we're also on Facebook. So, and we're on LinkedIn. So any way that we can help make this better and give you the resources that you need to save lives, that's what we're here for. So if you ever want to know what HSL stands for, it's helping save lives. So we're here to help you do that. So drop us a line if there's anything we can do. I'm going to head back over so that we can do that Pph video.
Great. Okay, we'll see you in a second. And I will actually put up our email if you didn't get a chance to hear it, or if you wanted to actually write it down. It's at the bottom of this page here. So again, hsl@laerdal.com. And those are Shane and my full names if you needed to address us. And Shane will be joining us in just a second. So if you have to hop off, please feel free. We're going to just continue this recording so that we can send you the full Pph install as part of the recording. And then you can have that when we get it to you. So feel free to hop off, as we know we have gone over the allotted time. Hi, Shane.
Hello, can you hear me now?
Yes, let me spotlight you.
Excellent. Okay, so we have done a delivery.
Yes.
And our little baby has came out and they've taken the baby, and now we want to start creating complications for mom.
Yes.
Now, that baby, we have Sim Newbie that's available. We have Newborn Ann that's also available. So if you wanted to sub out this baby for a higher fidelity baby that has pulses and talks and cries and breath sounds, we also have that solution as well. But for now, like I said, this baby is so good. We can actually get a little tub and let him soak in that little tub. Let him have a little bit of a spa day there. There we go. All right, so we're going to need this red foam. That's going to be really good for applying subpubic pressure, but that was more so for the ADM in regards to the shoulder dystocia. When you're taking off the ADM, it's essential that you lie SimMom down, and that's going to allow the hooks to become open so that we can actually slide this out. So I'm just disconnecting the power. I'm disconnecting the shoulder dystocia bladder, and then we're just lifting this off the hooks, where then we can actually disconnect the compressor that's inside of her. So this, I don't submerge this because this has some working parts here that I don't want water to get in, but I can submerge it up to this level, and then I just use a nice little cloth to clean all that out. Again, a mild dish soap really works wonders in getting that, that lube off. This tray, completely submersible. The placenta is submersible as well. So that can go under here. And just, there we go. Now the compressor just comes out. There's a green and a yellow Laerdal that just connect into the green and yellow Laerdal receivers. So everything is color coded, so it really works nice. Put that down here. What we're going to add now is I've added the SimMom birthing, I guess, blood or postpartum hemorrhage blood to this container. It has a really nice twist off knob, makes it very easy to fill. The other thing that I invest in is little silicone funnels. And these funnels will work really nicely when it comes to filling this or filling the inside of the birth canal so that you can get some more blood coming out of there. So let's add this. So this has a blue, so that goes to the blue. And I'm gonna have to apologize, since we moved the last camera, the overhead camera has decided that it doesn't want to play anymore.
Oh, that's okay.
Yeah, so I'm actually unhooking the clamp now once I have that on and sitting that nicely inside there. Next, we're going to want our Pph kit right here. So I have everything in a little tiny tray so that it's easy for me to get to and find. We're going to position this. Now, this is half the puzzle, is trying to figure out, okay, how does this go on? So this goes on just like this. And the way that I always look at this is that there's going to be an opening right here for the urinary bladder to come up through. And so I just match that up with the same thing that's in the hard ring. And then I can apply that right to the top. And we just make sure that the posts and the metal screws, I guess you could call them, are just all lined up. Because when this pinches down, we don't want the uterus to get damaged. So I'm just confirming everything looks good, and then I can start to screw this on. So I'm using the same screws that came off the ADM, except for this time there's an added screw because we can actually put a screw in the back. And that screw looks a little bit different. Let's see if I can.
Shane, I have a quick question, if you don't mind.
Sure.
I think this one is a little bit dependent on the comfort level of being with SimMom, but someone asked, how long does it take to prep SimMom for Pph after birth? And I know you're a pro at it, but
yeah, that's a fabulous question. So sometimes I tell people it could take 20 minutes for your first one. But once you've done this a couple times, 2-3 minutes is all you really need. And I'm kind of like taking my time here because I'm talking you through the process. So right now, I'd say a new user maybe that has done it probably 3 or 4 times, maybe 10 minutes. But as you continue to get even better and better, you can do this in 2 to 3. Usually what I do is there's so many learning concepts that are with the birth that I stop, take care of the birthing learning objectives and debrief those. And then I'll come back and do the Pph. The last thing that I'm going to hook up here, this is the Pph Boggy Uterus Hat. And this just kind of sits right on top of the uterus, because if you touch the uterus is hard. So this is a nice tonic uterus. And then what we're doing is we're adding a balloon to the top of it so that we can fill it with air and make it I guess we can make it atonic or boggy is the term that they like to say. And the boggy uterus, it just has a little green tip, and that goes to the green tip down here. All right. So soon as my fingers are all really slippery.
I can
There we
imagine.
There we go. So now we got that on top. It is essential, and I can say this a bunch of times, it is essential before you start inflating that boggy uterus that SimMom's belly has to be attached. There's a little pressure sensor in here that reads the pressure. And so
Right.
if we don't have that skin over there, it's just going to keep on filling and filling and filling. And
Yeah.
It could make for a very interesting simulation, but probably not the one that you're looking for. The other thing that you can put inside here is this little red sponge, and that's to give the SimMom the belly, the curvature that we're looking for, and also protect the ends that are here, because also with the Pph module, we can also have retained placenta so that we can actually use, let's see here, I got another tray. So if I wanted to start using placenta pieces, and I can bring that right in here, you can see that this placenta is not complete. And we can actually use this suction to connect to the back, and then with some lube, suction these into place so that practitioners, one, can recognize that it's not a complete placenta, or two, start to deliver therapies for that problem. SimMom also comes with IM injection sites, IV, pre-ported IV, so that you can start to push your syntocin, oxytocin, or any type of family of tocin that you're looking for to create that uterine contraction that you're looking for. I can put this away, I can put this away. All right. And like I said before, that compressor down here, this fluid chamber only has so much blood in it. So a lot of the times what I like to do is I like to fill SimMom's birth canal with some blood so that I'm not spending all the time filling up the birth canal and waiting for that nice trickle of blood to be coming down to really trigger that practitioners in that fashion. So here comes the belly. Remember, don't forget your 3mm plug. More so when you're taking it off, because you don't want to take off SimMom's belly and then you rip that 3mm off. So that 3mm connection. So it's just something to bear in mind of. I'm going to clip that in. And again, the whole reason, I'm not trying to hide anything from anybody. It's just in order to get that boggy uterus to inflate, I have to have this belly on, just so that it inflates and doesn't overinflate and then start causing damage to my simulator. If I switch over to the IPC, we're going to get out of this. We're going to, oh, okay, we're still stuck in this one. So we're going to continue without EFM. We're going to have to start LEAP all over again, because right now it's LEAP is saying, hey, you still got the ADM inside of that mannequin. And we can actually say, no, we don't anymore. So I'm going to exit this, exit LEAP only. And I'm going to try to start up my SimMom software again here.
Awesome.
Any questions so far?
There was someone who was just asking about, like, we can't make it bleed during delivery, but I think based on what you showed us, that you can kind of add some blood onto the baby or in the canal. That's kind of the simulated version of, like, you know, you can't do a PPH and the delivery at the same time.
Right. Yeah. So you're exactly right. So add more blood to the inside of the birth canal so that as the baby's propelling out, and then has that external rotation, will restitute, some of that blood is going to be coming out with that to give it some more blood. The other thing that I do, so that I don't have to add more blood inside, is I'll put out an OB sheet and I'll cover it with blood so that they can see that a lot of blood has already been lost before the baby. So it triggers them that way. So that's a great question.
Perfect.
Over to the IPC, you can see here now it says automatic delivery or manual. I'm going to go over to manual now because the automatic delivery is not in there anymore. So I'm going to go manual delivery. And that is going to bring me to a place inside the LEAP software. Thinking about it. There we go. I'm going to go manual mode because I'm not using an automatic mode scenario. I'm like a lot of our end users out there. Don't forget, there's also Scenario Cloud out there now, so that on a subscription base, you could have every single scenario available. And I'm going to continue without EFM because the baby is already out, so I don't need an EFM. and I'm going to start my session. So how do I control this bleeding? This bleeding is controlled by these little buttons down here. So uterus bleeding, I'm going to turn it on. And right now I have it set at 100%. So what's doing is it's pushing air into that canister full of blood. Let's get back to it's pushing air into that canister of blood. And then it's now starting to push the blood into I'm just going to double check on a couple things. Yeah, no, everything's looking great. All right, so now once this fills up, you're going to start to see the trickle. I might move this camera in just a smidge. So it's almost full. So again, I preloaded this with a lot of fluid so that the little bit of time right now, so right about, there it is. So now we have a stream of blood that's now being trickled from SimMom, and I can control that over here on the IPC. I can turn it down a little bit, or I can even just stop it for right now. I can just stop it. So that's what I like to do before my practitioners come. The other thing that I like to do is make my boggy uterus boggy. So you can see it's on hold right now. You can see that control right here. So I'm going to go atonic, and I'm going to put uterus pressure at 100, and we're just going to let that blow up. So right now, the system is putting air into that boggy uterus hat. And as I push down right now, I can feel, if I push really hard, I can feel that uterus underneath. But as I feel that hat inflate, it's getting squishier. Is that a word? Yeah. Are we allowed to use squishier?
Sure.
But I mean, in medical terms, we call it boggy. So we're not feeling that tonus uterus that we're looking for. We're just feeling some bogginess. And so this is when they're starting to massage. This is when they're using oxytocin and stuff like that. And I mean, it depends on what country and your protocols. I mean, they're using stuff like TXA and all this other kind of stuff. But they're starting to give uterine massage. They can even do bimanual massage to start to alleviate that. And once I get that pressure to a nice boggy that I think that my practitioners will appreciate, I can actually go back over to my IPC and I can click hold. So that means it will hold that pressure no matter how much we're trying to maneuver and manipulate. It will hold that pressure so that as they do better and better and better, I can now change my boggy uterus over to tonic. And as they massage, they're actually helping us push the air out of that hat, and they're going to get more of a focal down on that uterus. And they're like, oh, this is working. And then you can decrease the blood, increase the blood, and have that work out for you with whatever learning objective it is that you have. Either it's medications, procedures, positioning, gauze packing. I've even heard Foley catheterization is a solution, and also using a Foley catheter that can actually go in and expand and hopefully stop the bleeding enough to get to the OR to get this resolved. So that's your PPH. Any questions?
Awesome. There was a nice comment just to kind of, I guess, generalize here, but PPH not only depends on the amount of bleeding, but also BP and HTC level, HCT level. And then there was also a comment, because I know, Shane, you kept mentioning IPC, and someone was asking, does that mean instructor PC? So yes, good guess.
And I thank you so much for asking, because I just throw these things out because on my little board here, it tells me IPC. So it's instructor. It's instructor personal computer, instructor control computer. What's the P stand for? Now you got me thinking. Now you got me some. So P.
I think just like a PC,
I think it's instructor like PC.
Yeah.
Yeah, I think you got it right there. Yeah. But that's PPH, and whoever mentioned that, absolutely right. So what I'm doing is I'm just showing you how to do the physical characteristics of PPH. Absolutely. Throw in a tachycardia, throw in a tachypnea or tachypnea. There we go. I always have a hard one with that one. I used to always call it tachypnea, and everybody used to laugh at me, and it's a good chuckle. So tachypnea, throw in some blood pressure now that's decreasing. And yeah, you're really setting your healthcare practitioners to be stressed and really use their protocols and get more confidence and competent around mom's bleeding post-delivery. Awesome comments. I love it.
Another question, Shane, if you don't mind. Someone is asking, where did you preload the blood? I guess maybe it was at the very beginning, so it's possible we went over it quickly.
I'm going to remove SimMom's belly, and then before I remove SimMom's belly, I'm going to pause my scenario because I don't want you to bust that hat. And so you can see here, there's that 3mm cable. Make sure you take that out because you don't want to rip that. There's your belly out. There's your little boggy uterus hat. So we're going to take that off. And again, these are all very cleanable. The only thing I don't submerge again is I don't submerge the belly top because that has speakers in it. But that's that. So where did I preload my blood? My blood, I preload in two spots, two spots. So one is going to be right underneath this because I don't want to take all my blood from inside my container and fill up mom's vaginal canal because that will use up a lot of my blood. Well, not a lot of it. You'll lose probably there's probably about 150 to 200 mils down in her birth canal right now. I can move the camera now in a minute. But the blood itself from inside of SimMom is coming from this container right here. That comes with her. So the Pph is not a module with SimMom. She automatically comes with Pph, retained placenta, inverted uterus. She also comes with a C-section belly. The optional module that I really like for her is she can come with a non-gravid flat belly. Yeah. So if you are a program and you want to buy an adult simulator for like running adult sims, deteriorating patient that has nothing to do with obstetrics, she is your woman because not only can she be a non-gravid woman, but she can also be a gravid. So if you're looking for one simulator that can kind of cross over between two different departments, she is your gal. She has defibrillation posts, ECGs, a manipulable airway, surgical crike. She's built pretty much on the ALS simulator from the hips up. So if you need something that crosses over between two departments so that you can maximize your simulation dollars, she is a great one to talk to your client executive about. But there you go. There's your reservoir that we're filling with blood and sitting inside of her. And there's that little blue tip that matches to the blue interface on the inside of her belly. Great question. So I don't throw away anything. I love, I'll get a big 60cc syringe now and I will suck the blood out of inside here and I'll save it and I'll put that into Ziploc bags and then I can freeze my blood. I can add a little bit of rubbing alcohol to it so nothing grows inside of it after and use it again and again and again until it's all used up. So for tips like that, keep on joining into the HSL webcast and we will keep on adding tips so that we can make your simulation easier, effective, impactful, and sustainable. So is there any more questions that anybody would like to see with SimMom? Because I'd love to get back over to the computer and we'll get into Client's Corner.
Yeah, one question.
Sure.
One of them is, I don't know, Shane, if you have any tips for this, because I don't know that we have this, but anything for showing episiotomies?
Episiotomy. So there is episiotomy trainers out there.
Yes.
Inside of SimMom, she doesn't come with an episiotomy trainer. However, we have partnered with fantastic companies like Limbs and Things that have episiotomy trainers that we can line you up with and get you more information. So yeah, if that ever becomes anything like that, we can definitely help you out. Okay,
awesome. There was a question about the flat belly, but I'll just answer it out loud. It is a separate module. So she does come with all the things we saw today, but the flat belly is actually, or flat stomach, belly is a separate purchase. And that brings you to kind of, you could do ALS training as a regular patient or, early early pregnancy scenarios where she wouldn't be showing yet,
Mhm.
and things like that.
And
So,
needle decompression for pneumothorax.
yeah, she can do a lot. She's awesome.
Yeah. It's special. Like if a program comes to me and says, "Hey Shane, we have X amount of dollars to spend, but we want 2 mannequins, and we want one of them to be a birthing one." This is what my solution is. That, or then we would go into a Prompt Flex and a lower fidelity mannequin that might not achieve all your learning objectives. So
Right.
she is really good for hitting both of those.
Awesome. Well, thank you, Shane.
All right, I'm gonna go switch over.
Yeah, I'll let you switch over, and I'll see if there's any other questions I can answer in the chat real quick, but see you on the other side.
Perfect, we'll see you there.
Awesome. And I will see if I can maybe share my screen quickly for you guys, or maybe you just want to see Shane and my faces. I see there's a question about approximate cost of the flat belly. I don't have it off the top of my head. I would suggest reaching out to your Laerdal representative, your client executive, and they can give you the cost. Also, I know we have international viewers, so I speak in Canadian dollars and some speak in US dollars, and then we have all the other currencies. So we just say, if you can reach out to your client executive, that's probably your best bet, and they'll give you the exact pricing for the components that you're looking for. Oh, I love the picture, by the way. This is SimMom, I mean SimMan with SimMom on his arm, because, you know, that's how they roll.
All right, I'm back. Can you hear me over here?
I can, Shane.
Excellent.
I don't know.
Holy Lipton, there's still 60 people. We are way over the time. We love simulationists that are so excited to get into even this part. So if this is your part that you're here for, this is what we're here for. The Client's Corner. After every episode, we like to open it up to you to find out if you have questions about any of our products, or if you have any concerns, or you know, you want to start a simulation program and you don't know where to start, we can put you in touch with the right people. So this is a great time if anybody has any questions about any of the products or anything you've seen here. I see one question there by Harvey Parker. Is there plans to have the bellows extend longer? There is not enough time to suction the airway before the bellows retract. So then you are stuck with having to pull the baby out. Seems like the programming could be made to give a little bit more time to suction. That's some great feedback. We can definitely pass that on to our team. And I'm thinking in regards to like shoulder dystocia or any kind of retraction in between where the head is delivered. That would be the only question, Harvey, is I'm imagining the head is delivered. You shouldn't have to pull too hard. The one funny thing that we used to always say was, I used to have other simulation ask, you know, is that enough lube? And the first time that I hear that, I always say no. If you're asking if it's enough lube, there's always room for more lube. Add some lube. That should get the bellows to get it out. Make sure that your SimMom is updated to the latest greatest and your LEAP is the latest greatest, because that bellows, the mills going into that bellows will change. So again, you know, much like the breech procedure, you are right. It's a pretty easy programming thing, that the breech actually just puts more air into the bellows to push the rest of the baby out. So make sure you got lots of lube. And if there's any more insight into that question, feel free to send us an email and we can dive deeper, or send it along to the product manager for SimMom.
Yeah. And again, our email is down here. Shane, I don't see the chat right now, so just let me know if there's anything else. But I think we answered a lot of them in the moment. So if there was anything else, we're here probably for the next 5 minutes.
There is another question there from Harvey, and he's talking about the lining on the inside of SimMom. So if you look at the inside of the belly, there's like a styrofoam liner that kind of holds the speakers in place. Is there a workaround for that falling apart? That's a great question. I have seen it a couple times where that will dry out and become cracked and ripped and torn. After a class of 75 nursing students, that makes a mess. any insights. So if it was me and I had a belly like that was ripped apart a little bit, I would probably try a little bit of maybe Tegaderm to kind of hold that in place, or some kind of a fixed solution that creates like a barrier, because all that's in behind there is the speaker for the fetal heart tones and mom's gastrointestinal sounds. So that would be some of my quick solutions for that. Again, I can reach out to the team to see if there's any kind of workaround, but I would, yeah, because that can get kind of messy if it breaks up into small pieces. So maybe look at maybe trying to do a little bit of Tegaderm on it, see if that will stick to it. If not, I would probably apply like an affix solution. And if we have one of our moulage specialists around, they can definitely guide you in regards to what solution that they would apply. Almost like a rubber glue that you can kind of put over the styrofoam, so it protects it from cracking up like that. Again, Harvey, thank you so much. Those are great questions.
Awesome.
And by the looks of it, that is the only question. So with that being said, I still see a lot of people on, but I don't know. I think we can put a wrap to season 3, episode 1. We're going to be looking forward to the next episode. We're going to try to put this out, hopefully live from New York, or New York State, upper state, Wappinger Falls, right where the home of Laerdal is in the USA. If you have comments, questions, concerns, please reach out to us. Let us know how we're doing. Let us know how we can be better. Because at the end of the day, Alyssa and I, this is what we do. This is what we do for fun. And all we want to do is help you save some more lives in your practitioners, in your community. So,
yeah, well said. And congrats to the winners. We will be reaching out to you to know where to send these two. So thank you
Awesome.
for joining us. This was a long episode, and I'm surprised so many people are still on. This is awesome.
Yes. Thank
Thank
you.
you guys. And you know, the recording will come out in probably tomorrow or early next week. So take a look out for that. Otherwise, you can find all our episodes on our website or on YouTube. So yes, and yes, thank you, Anna and Ingrid. Great comment,
Yes.
Bridget.
Thank you for joining us today.
Yes, we're surprised you guys are still on. It's very late for you, but thank you so much. Such insightful information, and you can sign off as well if you wanted to say something to the audience.
Huge thanks to you, Alyssa and Shane, for sure. And also actually to add on to the 2 given MamaBirthies, we have a shipment to UNICEF in Tanzania going. So you have just donated 2 MamaBirthies going to Tanzania.
Amazing.
Congratulations.
That's so cool. Thank you so much, Anna.
All right. Well, thank you, everybody, and stay tuned for next episode.
All right.
Thank you.
Bye-bye.
Thank you.
Bye.
Bye.